Okay. Again, let me know if I'm going too fast or anything like that. Okay. So let's get started with something that's really, really basic, and it would be nice if you guys can answer as well. I want to make this a little bit more interactive because it's easy and you guys know it. What are the two things, that's why there are two arrows, that you're thinking of if your patient presents with sudden painless bleeding with bright red blood? What are the two things? Even if you guys can say just one, I can fill you in. Of course, this is an obstetrics patient, so she will be, let's say she's 32 weeks gestation. She comes in with sudden painless bleeding with bright red blood. Let's say she was out having dinner and then she felt a gush of blood and she went to the washroom and she saw that she had a lot of spotting.
Uh,
Sorry, I couldn't.
Placenta
that's
previa.
previa.
Yeah, exactly. So one of them is placenta previa, and there's another one, kind of sounds the same.
Vasa previa.
Exactly. So you guys got it. So it's placenta previa and rasa previa. And anybody knows the difference between these two? So basically, rasa previa is what happens in rasa previa is I'm gonna try and draw. I'm gonna try and get better at drawing. So if this is the uterus and this is the placenta, it basically means that vasa previa is more to do with the fetus than placenta previa is. And the reason I say that is because vasa is vessels, right? And so the uterine vessels, they get entangled in the placenta. And what you need to do when you're thinking of vasa previa and the vessels of the fetus is that you need to find out if the bleeding is from the fetus or the mom. Okay. Placenta previa is always going to be just the placenta that is bleeding. Vasa previa, it's just slightly more complicated in that sort of sense that it could be the fetus that is bleeding. And obviously, if the fetus is bleeding, even a little bit of blood loss could be really, really dangerous. And does anybody know the test that you do for establishing whether in Vasa previa, is it the mom who's bleeding or the baby? It's called the apt test. Okay, we'll talk about it a little bit more. And again, I want to highlight this in this class that you deliver the baby as soon as it's more than 37 weeks. And I want you guys to remember the weeks over here. If it's more than 37 weeks, you have to deliver the baby. If it's not, you can do, like, if she's only like 22 weeks, you can do supportive measures. Let's say you have a question where you have sudden painless bleeding with bright red blood and the patient is 19 weeks gestation. What are you thinking of then? Any idea? Are you thinking of the same things? Are you thinking of something different? What would you even be considering this? Any idea?
Maybe ectopic.
Yeah, it could be ectopic. So that's good too. But would you even really, if you get 19 weeks pregnant and you get these two as options, can you tell me why you wouldn't really even consider these two things? She's 19 weeks. It's because, do you remember the gestational age for abortion? If it's less than 20 weeks, it's just that's what abortion is. Okay. Over 20 weeks, then you have to see what it's actually called. But if she's like in this case, if she's just 19 weeks gestation, you wouldn't even be thinking of it. Then it's just plain abortion, right? So they can confuse you with that sort of thing. Like you have to take into account the gestational age a lot. And if you miss it, you say, oh yeah, I'm gonna do I'm gonna think that 19 weeks can even be like a vasa previa. Like, no, she's too early. It's you're gonna be thinking of abortion. So I just wanted to put that in. Now going back to the apt test over here. So what you do is you put an alkali, and if it turns pink, then it's the baby's blood. And obviously, you have to worry a lot more if it's the baby's blood. If it turns yellow, it is so pink versus yellow. It's the
The
mom's blood.
moms.
Yeah, exactly. And it is also pretty serious, but it's salvageable if you have a lot of pink and the baby's bleeding a lot. It is a very high emergency, and the survival rates for the baby is going to plummet. Okay. So that's an investigation that you should do if you're thinking of vasoprevia. And again, cesarean delivery is vital over here. Um, can you tell me if you have a patient, and this could be a very easily a NAC case too. Let's say she's already diagnosed with placenta previa via ultrasound. Okay. Um, do you know which investigation you absolutely should not do in placenta previa? Like if you do this investigation, you would fail that station.
Oh,
The tact,
The what?
when you measure with your fingers.
Yes, exactly. You're not supposed to, because every other obstetric case almost, you're like, oh yeah, I need to examine you, right? And in the NAC, we'll discuss this more in NAC classes, but you never actually examine the patient because she's a participant, right? But you have to say, okay, I'm going to examine you and stuff like that. But if you say that in your NAC case and she's placenta previa, you will fail that station. So just keep in mind, you never ever ever like examine the patient with your fingers or um, probe the patient with placenta previa because it can have really, really bad consequences. Okay. Just wanted to.
That and vaginal ultrasound.
Yes, exactly. So you do an abdominal ultrasound. But in like again, if it's a NAC case, you can't diagnose it without an ultrasound. So they would probably say, like the patient would be like, oh yeah, I on my third trimester screening, the doctor told me I have placenta previa, and now I have sudden painless bleeding. And let's say she's already 38 weeks pregnant. So if this next scenario comes to you and you have to counsel the patient on the steps that you would be taking, um, what would you guys say? What would you guys say if this was an NAC scenario? She's 38 weeks pregnant, right? She was diagnosed with placenta previa already on ultrasound, in her other scans, and now she presents with sudden painless bleeding. This is an NAC scenario, and you have to counsel her. What is something that you would say? Like, this is something that we would consider doing right now.
Deliver the baby?
Exactly, it's right here. So you have to counsel her on saying that, listen, I know you're 38 weeks pregnant, but we're gonna have to prepare for delivery because your placenta is bleeding. Okay. And we'll discuss this more on like how you counsel patients in the NAC and stuff like that. But if she's 38 weeks pregnant and you go like, oh yeah, we're gonna do bed rest for you, or we're gonna give you drugs, and you don't mention, preparing for delivery, that will be a huge mistake because then imagine if her bleeding gets worse and you've tried all of the supportive measures like you put her on her left decubital side, it's obviously it's not going to work. And if you don't tell her, if you don't want her that delivery is something that you're considering, you're probably going to page obstetrics and they're going to be like, we have to deliver right now. And then the patient's not prepared at all. And it could be, an ethics case too. Like, oh, my doctor didn't tell me that this is something you're considering even. Okay, so just make sure the patient is aware of everything that you are planning in your mind, which is why they give like they want IMGs to do the NAC, is because I think in other countries, especially the countries that I'm from too, like India, we don't necessarily inform the patient of what we're planning in our mind. But in Canada, you have to tell them, okay? Because you can't surprise them with, oh yeah, okay, never mind, we're delivering you. Because that's what they're testing on the NAC. That's why IMGs have to give the NAC and not CMGs. Okay. So I just wanted to touch on that. Again, let me know if there are any doubts and stop me at any point. Okay, now we're gonna do antepartum bleeding. So uh just wanted to like summarize this kind of. We already discussed placenta previa and vasa previa too, is antepartum bleeding, but it is, you have to know that vasa previa and placenta previa are painless. Another huge problem that can happen is placental abruption. So if that same patient said, "Oh, I'm getting insane back pain," or "I'm getting cramping," or I'm getting tenderness over here," you're going to think of placental abruption. Okay, that is the main distinguishing feature. In fact, if she's in pain, you're it's even easier for you almost, because you don't have to distinguish between placenta previa and vasa previa. Then you don't have to do the app test. You don't have to worry about the fetus bleeding like that. Okay. Um, and so a placenta abruption will present almost like present placenta previa. It'll just be really, really painful. Again, it's a sudden onset. So, for example, you can take the same patient, she's out for dinner. Suddenly, she gets insane cramping and blood loss. And let's say she's like 38 weeks pregnant. Okay. Um, you're gonna start thinking about this. I also want to contrast placental abruption with uterine rupture. And the only um, you know, difference of this is that you will have loss of fetal station and fetal deterioration. So in placental abruption, um, you guys know what it is, right? The main difference. Uterine rupture, it's in the name. Your uterus just ruptures, and you literally can feel the fetal parts over here. So if this is the mom's tummy, this is her head, this is her legs. You can, if you feel, you can actually feel sometimes like the hands or the foot coming out of the uterus. Is very scary. Probably it's probably not going to be salvageable. And that is why you get the loss of fetal station, and you have absolutely no uterine contractions. Anybody knows why there wouldn't be? It's like pretty logical why there wouldn't be uterine contractions and uterine
Because
rupture.
because uterus is ruptured
Exactly,
already.
exactly. Yeah, exactly. The uterus is ruptured. So if you have a patient and she's having contractions and she's having sudden onset of vaginal bleeding and it's painful, you have to note that, okay, she is having contractions, right? I cannot be thinking of uterine rupture, because uterine rupture is really scary. It's not common at all, and it's a very complicated case. I'm going to think of placental abruption then. Okay, and this again, all of these can be NAC cases. The MCC is pretty heavy on obstetrics. You have to know what to do, and at the same time, especially in the NAC, you have to make the mom as comfortable as possible. Okay, you have to know what you're planning and stuff like that. So if you have a NAC case with placental abruption, it's an emergency. You have to tell her it's an emergency. You have to tell her we might be considering delivery. You have to tell her what you think it is. And all of these things you have to do in 8 minutes. And you, in your mind, you also have to be like, okay, I need to tell her what investigations maybe I'm doing. And then at the end, also they can ask you, okay, what are your investigations and your differential diagnosis? So you have to make sure at least your theory is correct. Okay. Because if you have a patient who, if you mix up any of these and you think placental abruption is uterine rupture, and the patient is having contractions, right? You're gonna probably not do really well in that stage. Okay. Any any doubts at all? Of course, normal labor. Don't confuse blood show with just normal labor. And the reason is it's a very small amount of blood tinged. They normally will not confuse you. If they give you a normal labor case in your neck, they will be fair to you. They won't be like, oh, it's hurting her a lot as well. It's like it's Braxton Higgs. It's like, they'll make it pretty clear. For the most part, I think they will want you to know just the basic difference between these. And it is pretty simple to know the difference, right? I don't think you guys will be confused, at least now. Yeah, go to the next one. So I put this picture in because again, this can be a NAC case. So what is happening here? Does anybody know? The female is lying here, and you told her to just go here, like just roll over. Do you know anything that would what this position is called, or like what?
So is it to increase venous return? Because she needs to be on the left lateral position.
Yes, exactly. Exactly. It's the left decubital position. So you guys were right. And it basically what it does is it increases cardiac output for the mom. Okay. So that's something that you can actually say in the NAC that if it's an emergency, the first thing you can be like, okay, why don't you go into left? Conservative measures you can do in the station itself, and then you can tell her the plan later. Okay. So if you do this, you're probably going to score like over 2 standard deviation. Okay. I just wanted you to know that this is a very easy way to just tell the examiner you know this. Okay. Okay. Now we talk about preterm labor. So all of those bleeding cases can also be tied into preterm labor because you can very easily get like a 25-week-old patient who bleeds, and you have to, tie in what the bleeding causes with preterm labor. And if it's salvageable, for example, placenta previa with not a lot of bleeding, in this case it's still salvageable, so you have to know how to do it. The converse is she's 25 weeks and it's not salvageable, you have to know how to do preterm labor and what it entails. Preterm labor again is between 20 to 37 weeks. Anything below 20 weeks would be again abortion. It's not called preterm labor. And how do you prevent preterm labor? So for example, let's say you get a patient who has a history of preterm labor. Okay, and she comes to you, and this could be very easily a NAC counseling case. She comes to you and says, I want to prevent that in my next pregnancy. So you're going to have to talk to her about cervical cerclage, just very basic. Don't go into depths in-depth explanations with your patient on what cervical cerclage is. Just say, yeah, we're going to just, tie your cervix around. It's not a major surgical procedure. Just going to tighten it up so as to prevent preterm labor. That's it. You're done. Okay. Don't go into the details of it. You can also give progesterone. So if you diagnose this patient with, okay, she's had a history, you can say, okay, just put progesterone until 36 weeks and intravaginally, and that will help with preventing preterm labor. A very important thing that people really do miss out on is just lifestyle modification. So if she's a smoker, if she could even consume alcohol, if she exercises very heavily, you need to ask this in your NAC cases because it can be just like the make or break. Okay. So all of these, they seem too easy to be an MCCQE question, so they're probably going to ask you this in the NAC. And if you nail these 3 things, just, again, when it comes to cervical cerclage, because it is like invasive, you don't say, yeah, we're going to do this. You say, this is an option, and you have to tell me if you're okay with it. Okay. Again, with progesterone, it's an option. Lifestyle modification, again, like if she has unhealthy habits, and it is your duty in the NAC to find out if she does and counsel her on that. And this is probably going to be the most important thing. Even if you don't talk about cervical cerclage and you miss out on the fact that she's a smoker, for example, or she has hypertension or some reversible causes, if you miss out on that, it's probably going to reflect worse on your score. Okay. Okay. Can anybody tell me what tocolysis is? It's kind of like in the name. Lysis is stopping. Toco is like movement almost. So if you have the same patient, let's say she's 25 weeks and she's going into preterm labor, what you can do is something called tocolysis. So again, it can be a NAC case as well. It can also be an MCCQE case. The drugs that you give are nifedipine and indomethacin. And can anybody tell me why you would want to give these two drugs? So either these two and this. So two separate causes.
Or
Long,
depending on the age, long
long mat-
maturation,
Yes, lung maturation. And MGSO4 would be for what system?
seizure.
Yeah, exactly. The CNS system. So make sure the CNS is matured. So if you want to tell your patient this, you say, okay, we're going to give you betamethasone just to ensure your baby's lungs are matured enough, and magnesium sulfate to make sure the nervous system is mature enough. Okay. This is our same patient that we're talking about. She's your NAC case right now, because I think that this is kind of easy. Maybe it could be a really easy MCCQE question, but if this is a NAC case, you guys are going to nail it, right? So the requirements for doing tocolysis is very, very important. And this is where it could also be an MCCQE case. Obviously, the fetus has to be live, okay? Has to be intact membranes. And the cervical dilation needs to be of less than 4 centimeters. If she's fully dilated, these drugs are not going to work. So how they can do an MCCQE case can be, your 25 weeks mom comes in, she's let's say she's 7 centimeters dilated, or let's say she's 8 centimeters dilated. Or what drugs would you consider? In this case, you wouldn't consider this. You would probably just, if it's already 8 centimeters dilated, you cannot do any of these drugs. Or they can even be like, give you one of these contraindications and say what drugs are contraindicated in this. So say our 25-week patient is bleeding as well. What is contraindicated? And they can give you this. And they can give you these drugs too, which are not necessarily contraindicated. But if you do tocolysis for a patient who's already bleeding, you're probably going to worsen the bleeding. So just make sure you're not giving these two drugs unless it's absolutely okay with the mom and the fetus to give it. Okay. So you cannot give it if the mom is bleeding. Like any of the antepartum bleeding cases we talked about. You cannot give it if she is gestational diabetes or hypertension, or any severe heart disease. And if the fetus has anything wrong with it, you cannot give it as well. And obviously the fetus has to be alive when you give it. So I mean, they could easily give you a case where 26-week gestation patient comes in, severe IUGR, you cannot detect fetal heart, right? What would you give in this case? And they say, oh, nifedipine versus just a C-section. I don't know. Logically, you can be like, oh, let me try and like deliver the baby normally, or let me try and like stop the thing right now. It's just IUGR, right? I can think about it later. No, you can't do tocolysis in IUGR patient. And why is that? Is because it will worsen the IUGR and it will probably cause your baby to die. Okay. So just remember these things because this can be tricky. Like because tocolysis seems like a really easy thing, like, oh yeah, just stopping preterm labor. But if you don't fulfill these criteria, you can actually worsen the cause of preterm labor and cause more devastating consequences later on. Okay. Okay. I wanted to touch upon two things that seem like they're unrelated, but I want to tie them in so you guys have like a logical bridge connecting these two things. Okay. So I want to draw your attention to this uteroplacental insufficiency. So everybody knows this is super easy for fetal growth restriction. If it's symmetric versus asymmetric, symmetric is going to be if something is wrong very early on. So in the first trimester, either chromosomal abnormality or an infection. We'll talk about torch infections later. And I do have a slide asking you guys about what the torch infections are. And I know I don't want to put you guys on the spot. So If you know what they are, you can either note them down or think about them, and it'll be great if you could answer later on. So anyway, so if that is wrong in the first trimester, you're going to have symmetric fetal growth restriction. Everything is going to be, there's going to be a global growth lag. So everything is going to be deficient. And what you do is you just keep doing tests and see if it's salvageable, or is the IUGR so bad that you have to terminate the pregnancy. Asymmetric will be something later on in the pregnancy. For example, uteroplacental insufficiency, and very easy is maternal malnutrition. It's not that commonly seen in Canada. It is more commonly seen in poorer countries like my country. I saw a lot of asymmetric fetal growth restriction just because of maternal malnutrition, because India is poor, right? That a lot of people are not as privileged as people over here. So over here, I don't think you'll get a case of maternal malnutrition. You have to worry about this guy, which is placental insufficiency. And you have a head sparing growth flag. So because the head is already developed, it'll be fine. Everything else will be down. Okay, super easy. You guys already know probably the difference between these two. I want to, like I said, bring your attention to uteroplacental insufficiency. So again, it's in the name. Your placenta is insufficient. So what the placenta does is it gives everything to the baby, like oxygen, nutrients, everything. If it's insufficient, there are going to be consequences. So can you tell me what would a post-term placental insufficiency cause? There is a name for it. I don't know if you guys know what it's called. You have all of these things. So he's small for his age. He has wrinkled, peeling skin, long, thin body. Maybe he's 42 weeks gestation. And some of the moms, they refuse to do, induced labor. And your placenta is going to be not that quote unquote sufficient at 42 weeks. And then you'll have all of these things. So increased scalp hair, decreased languor, which is the natural like peach fuzz that's on a baby. It's basically gonna look like an old baby. Okay, if that makes any sense. And these are the complications that can happen. So if she refuses to induce, probably going to send her baby into the NICU. But I want to draw your attention to the fact that you cannot force anybody to induce labor if they have like religious obligations where they don't want to induce labor. You have to, be compliant to the mom's wishes, even if the baby is deteriorating very significantly and you know that it's bad. You can just tell her, like, your baby can have meconium aspiration, where he can have his first poo in the uterus itself and then aspirate that, or breathe it in, and that can have like severe lung consequences. He can have low blood sugar and can even develop seizures right after birth. If she still doesn't want to induce at a really she's really post-term, you can't force her. And this could very easily be a NAC case too. Like you have to comply with the mom's wishes, even if it's against medical advice. Anybody know what this sort of thing is called? It's pretty easy. It's called fetal post-maturity syndrome. And again, the thing is, they could give you this in an MCQE case too. Like they could give you some of the clinical findings and say, oh, what would be the possible complications of this patient? And then they could give you one of these. They could also give you something that's like completely out of the blue, like, I don't know, bleeding. No, that's not really part of the fetal post-maturity syndrome. So, and it's caused by basically the same thing, but it's in two different time periods. So over here, she's going to be in her second or third trimester, and she's going to have placental insufficiency. And over here, it's because she's waited too long and probably not induced. She's going to have post-term placental insufficiency. So kind of bridging those two things, even though they're really, really different, obviously. But it's caused by almost the same thing. So I wanted to just highlight that. Okay, this slide is about placental insufficiency in general and what can cause it. So it, regardless of if it's either second, third, or post-term placental insufficiency, it can be caused by any of these things. So hypertension, diabetes, any autoimmune conditions, these are all the maternal. Anything that's wrong with the mom basically can cause that. Again, low socioeconomic status. I saw this a lot in India. People who are, they can't afford good nutrition for the mom get a lot of the placental insufficiency cases. Over here in Canada, I'm expecting more of the hypertension, the gestational diabetes, something wrong other than just not getting access to proper nutrition. For the fetus, again, torch infections, chromosomal abnormalities, and multiple pregnancies. So talking of multiple pregnancies, do you guys know any scenario where if there are two babies, one of them kind of looks like this, one of them looks like this?
Twin transition.
Exactly. Yeah. So we're going to talk about that next. Any questions on the previous slides at all? Any doubts or anything that you want me to go over? Yeah, I guess not. We're gonna do twin transfusion now. So this is seen in monochorionic multiple gestations, and the reason why this is important is there are different types of cases that can happen. But if the twins are sharing the same chorion, that can lead to twin transfusion syndrome. So very easy. Basically, one guy gets a lot of the nutrients and oxygen, one is deficient on them, and this can have very bad consequences for both of them. Obviously, the donor is going to have really bad consequences like anemia, hypertension, oliguria. So everything is going to be low for him. But at the same time, this person is going to suffer too, because the placenta, when the mom has twins, is really, really big. It's more big than, like, obviously, because it's for two people rather than one. He's gonna have more cells, hypertension, and he's also going to have serious consequences. So if they're really unlucky, you can lose both twins. And if not, it's more likely for the recipient to survive than the donor. But again, don't discount the fact that even the recipient will have all of these, so polyuria, polyhydramnios, and it's not necessary that he'll have all of them, but it's important to manage the recipient as well, because he's going to have serious consequences as well. Okay, so just really quick, twin transfusion syndrome. I don't know if oh yeah, I think this is one of the last slides. Can anybody tell me what the torch infections are? So T for
Toxoplasmosis.
yes. O for others, but can you tell me one of the others?
Um,
Very common. Starts with S.
Syphilis.
Yes, exactly.
Syphilis.
Yeah.
Yes.
R for
Rubella.
yes. C for
CMV.
Cytomegalovirus.
yeah. CMV. H for
Herpes.
yeah. Exactly. So this is straight from Toronto Notes, and just keep in mind, can be a very easy MCCQE thing. Like you get any of the, so torch basically is IUGR. What they could do is like they could give you a scenario which looks like IUGR and then ask you, what test should you run? And one of them could be an HSV test, or one of them could be like anything. So they could tie IUGR very easily with the torch infections and just ask you about the tests. Super easy. You guys already know it. And yeah. Okay, I wanted to quickly go over some really easy cases. I feel like preeclampsia and the treatment of preeclampsia, like everybody knows it really well. I'm thinking it's going to be more of a NAC case than an MCCQE test because I mean it's not that complicated. You just have to know how to diagnose it. Obviously, it has to be more than 20 weeks gestation because remember, like everything below 20 weeks, you're looking at abortion and just make sure you have that down. So, yeah. Um, remember you have thrombocytopenia, creatinine increased, transaminases. You can have pulmonary edema and visual or cerebral symptoms. And the treatment would be hydralazine or labetalol. Just 1 second. I'm just gonna pause this really quick. Yeah, make sure that there's no seizure. So prevent eclamptic seizures. Okay. So again, this is probably going to be a NAC case. You could even have these labs outside the door, and you have to figure out what's wrong. They might not tell you that it's preeclampsia before. So just know the basics. It's really basic. Gestational diabetes, again, very easily a NAC case, just cancel on dietary modifications. And if it's really bad, just know it's insulin. Know these cutoffs that 1 hour postprandial, you have to have it as less than 140, 2 hours is less than equal to 120, and fasting of 95. Okay, super easy. You guys already know this. And yeah, so those last 3 slides were probably gestational diabetes and preeclampsia. Definitely NAC cases. I don't think they would ask you this in the MCQE unless they tie like pulmonary edema in with preeclampsia or something like that. But yeah, that was the first part of. I'm gonna pause this recording.